Good evening and warm greetings to respected dignitaries, guests of honor, experts, MMC observer, CIP OBs and EBs, MAHA-IIP President Dr. Ramakant Patil sir, MAHA-IIP Secretary General Dr. Amol Pawar, all the dynamic speakers, MAHA-IIP Women Committee Chairman Dr. Sonali Shirbate, Co-Chairman Dr. Neha Singh, my Women Committee Zonal Coordinators, and all the viewers who all have joined through Zoom and YouTube for this popular Tuesday Takes program. I, Dr. Manjusha Sherkar, Senior Consultant Pediatrician from Chhatrapati Sambhajinagar, MAHA-IIP Women Committee Convener, and Dr. Dipti Deshmukh, Consultant Pediatrician from Latur, MAHA-IIP Women Committee Zonal Coordinator, are today's moderators. We welcome all on behalf of MAHA-IIP and MAHA-IIP Women Committee 2023. Friends, we all know Tuesday Tech is online webinar designed in such a way that many speakers from all 5 zones of Maharashtra gets a platform to present their knowledge. It's a theme-based webinar on day-to-day common clinical topics. Today's theme is infectious diseases. We have 2 experts to guide us regarding this topic. I welcome Dr. Mihir Sarkar, Professor of Pediatric HOD PICU, Unit Kolkata. Welcome you, sir. I welcome Dr. Maninder Dhaliwal, Consultant Pediatrician PICU, Amrita Hospital, Delhi. Welcome, sir. Hearty welcome, guest of honor, respected Dr. Basavaraja, sir, CIP President-elect 2023. Hearty welcome, sir. We are very much delighted to have you here, sir. Welcome. I welcome today's MMC observer, Dr. Vaibhav Pustake, sir. Sir is Consultant Pediatrician from Nasik. Hearty welcome, MAHA-IIP President Dr. Ramakant Patil, sir, and Secretary General Dr. Amol Pawar, sir. At the outset, we thank Ramakant, sir, and Amol, sir, for giving us an opportunity to present this program before you all. I request Dr. Ramakant, sir, to say a few words of guidance and welcome address. Over to Dr. Ramakant, sir.
Thank you, Manjusha. And it is so pleasure job to be giving a word of introductory words. And it is so nice that we have got CIIP President-elect, Dr. Basavaraja, sir, as a guest of honor. It is IIP is being honored by his presence virtually over here. And really the experts are like as intensivist Dr. Maninder Dhaliwal. And he's an intensivist for last 12-15 years and has given many times insights in many conferences. And Dr. Mihir Sarkar, a thorough infectious diseases specialist, and particularly he has got vast experience of adenoviral infections since January 2023, and he had particularly in east part of India, this adenoviral infection is really notorious, type 7 and all disseminated adenoviral infection and all immune dysregulation. Fortunately, we have got lesser incidence of that. We are having more of a pharyngoconjunctival fever and different adenoviral infections. And I really congratulate Manjusha and Dr. Dipti Deshmukh and Women Committee Chairman Dr. Sonali Shirbate and all zonal coordinators like Dr. Sucheta, Dr. Neha Singh, then Dr. Pallavi, Dr. Sonal, Dr. Shilpa. So they are really taken this Tuesday Takes to newer heights. And what a wonderful topic selection like monsoon maladies. We have got dengue in full swing, adenoviral infection. This year it is really playing havoc. And we have got, Basavaraja sir, we will like to tell you that we have given chance, or particularly we can say that we wanted to groom all the pediatricians and younger ones. All the speakers in this Tuesday Takes have been less than 40 years and from the town places and periphery districts. And full credits goes to Dr. Sonali Shirbate, Manjusha, Neha, and the team. And today also we have got speakers who are very young and dynamic, and they will, I don't want to take more time, but I welcome Dr. Gargi, Dr. Ganesh, Dr. Sanjeevani Magar, Ninad, and Dr. Soham, and they will definitely enlighten us on this topic. And we are more than eager and all ears to listen to have expert comments from Dr. Maninder and Dr. Mihir Sarkar. Thank you, Manjusha. I hand over baton back to you.
Yes, thank you so much, sir. Your encouragement is always precious for us. Thank you so much. Now I request our Honorary Secretary General Dr. Amol Pawar, sir, to give his welcome words. Dr. Amol, sir is there?
Yes. Am I audible?
Yes, sir. Yes, sir. You are audible.
Loud and clear.
Network is unstable, so I'm keeping my video off. Thank you, Manjusha ma'am, for inviting me to speak a few words. This is very nice initiative started last year with Maha IP Women Committee, and as many things have been told by RD sir about this structure of this program. So without wasting time, I welcome dignitaries, Dr. Basavaraja sir, President-elect, my big brother, then good experts, Marinder sir and Mihir sir, and all the speakers and all the delegates, PG students from across India who have joined for this program. So without wasting time, I ask you to proceed further in this session. Thank you.
Okay. Thank you. Thank you so much, Amol, sir. Thank you so much. Can I request our special guest today, Dr. Basavaraja, sir, to give us inspiring guidance, please?
Thank you, Dr. Manju Shekhar, madam. So, really, Maha IAP led by our Honorable President of Maha IAP, Dr. R.D. Patil, and the Secretary who has been galvanized, Maharashtra IAP. Whenever we talk about in India, now everybody looks at Maha IAP for innovation, creation. That's how R.D. Patil and Dr. Amol Pawar together, they taken the Maha IAP to the greater heights. Another crown in the jewel is our Maha IAP Women's Committee. Sonali Shirbete, Dr. Manju Shekhar, Dr. Neha Singh, Deshmukh, Deepti Deshmukh, and many of the IAPL who has been a role model to the rest of India, how the parent body and women's committee can work together. This will be the one of the benchmark and the role model to the other IAP branches in the India. That's how the women's committee of our Maha IAP has been doing in the proactively taking the academics to the greater. Today's topic, which is a very, very relevant. The moment we talk about an intensivist and an emergency physician, especially in the month of the moment the monsoon sets in, most of the time we look at the infectious disease. Infectious disease is one thing where the majority of the death which is taking place in an emergency and intensive care because of infectious disease. Today's topic is a very, very, very relevant to the practicing pediatrician, emergency physician, intensivist, and also infectious disease, especially. The today's topic is very relevant, especially Dr. Maninder Dhaliwal and Dr. Mihir Sarkar. Mihir Sarkar, to special mention about Mihir Sarkar, is a one who has been reported in a number of deaths which has been taken place in West Bengal. After that, the whole India has came into the limelight with adenoviral death. After that, we could be able to save the thousands of children, all because of this our young energetic and excellent academician, Mihir Sarkar, who has done a great job to guiding all the Indians. Really, with that, Maninder Dhaliwal, I am sure today's topic is also going to be very, very useful to the practicing pediatrician. Wish you all the best. Once again, Maha IAP doing a great job. Amol Pawar and Deshmukh and our Women's Committee, Dr. Sonali Shirbete, Manju Shekhar, Madam, Neha Singh. Wish you all the best for your. Thank you.
Thank you, sir, for that encouragement. Thank you so much.
Amazing words.
Very nice.
Thank you, sir. Thank you.
Is our MMC observer, Dr. Vaibhav Pustake, sir, has joined Neha? Okay. Now I request our guiding force, Dr. Sonali Shirbate, Maha IAP Women Committee Chairman, to encourage us. Over to Sonali.
Thank you, madam. Not wasting much of time. We are very fortunate today that Dr. Basavaraj sir had joined for our session. So I welcome him. Also for the extreme guidance, Dr. Ramakant Patil sir and Dr. Amol Pawar sir, because without their guidance, we can't do anything. So especially in selecting topic and getting the MMC points, they helps us a very lot. So thankful to them, and most thankful to my all EB ladies who had worked very hard to bring speakers from all zones of Maharashtra. So I'm very thankful to all my lady EBs, Dr. Mangai Sinha, Dr. Grivita Raikar, Dr. Shilpa Dudgaonkar, Dr. Nivedita Patil, Dr. Sonal Shinde, Dr. Pallavi Patil, Dr. Manjusha Giri, Dr. Swati Patil, Dr. Sucheta Pofre, Dr. Dipti Deshmukh. All these have worked very hard for success of this session up till now. And I'm most fortunate today that we had got the judges, Dr. Maninder sir and Dr. Mihir sir. With their guidance, we are moving further to this session. And most thankful to our WC co-chairperson, Dr. Neha Singh, and convener, Dr. Manjusha ma'am, as well as today's coordinator, Dr. Dipti Deshmukh madam, for this session. So, and as well as our faculty speakers, Dr. Gargi, Dr. Sanjeevani, Dr. Ninath, Dr. Ganesh, and Dr. Soham had worked very hard for this session. So let's move further in this session and let's welcome them, all our speaker for the session. Thank you.
Thank you, Sonali. Thank you so much. I really appreciate Neha's contribution also for driving this Tuesday takes. Thanks, Neha, also. Before starting our session, let me take opportunity to introduce today's experts. So, Dr. Mihir Sarkar sir. Sir is a professor of pediatrics, head of PICU unit, Medical College, Kolkata. Sir is a teacher of College of Pediatric Critical Care, India. Also, he is a chairperson of Society of Pediatric Intensive Care, Kolkata. Sir has 45 publications on his name, as well 20 international and 25 national presentations as a faculty in national and state level conference of pediatric intensive care. Hearty welcome you, sir. Dr. Maninder Dahiwal, sir. Sir is a senior consultant at PICU Pediatric Pulmonology Unit at Amrita Hospital and at Amrita School of Medicine, Faridabad, Delhi. Sir has done his MD Pediatrics and DAA and Fellowship in Pediatric Critical Care. He has received James Flett Endowment Award in 2006 and PICU Fellowship Gold Medal in 2011 and Asian Patient Safety Award in 2014. He is IIP ALS BLS Haryana State Coordinator. Sir was Director of PICU Medanta, the Medicity, Gurgaon in 2020 and 22. Sir is editor of Academic Pulse and Pulse. Once again, Maha IIP, welcome Dr. Mihir Sarkar sir and Maninder Dhaliwal sir. Hearty welcome, sir. And for the further proceedings, I hand over mic to my coordinator, Dr. Dipti Deshmukh. Over to Dr. Dipti.
Thank you, madam. Thanks a lot. After the inaugural speech and inspiring words, we will welcome our young brigade. There are 5 speakers from respective zones. We will move to first speaker. She is Dr. Gargi Bangar from IIP Navi Mumbai. Dr. Gargi is going to speak on presentation and diagnosis of dengue fever and dengue shock syndrome. Please, can you share your screen, Dr. Gargi?
Yes. Hello, good evening, everyone.
Yeah.
Just hold on.
Is seen and audible also.
I am getting a list of participants in the waiting room and I'm not able to see my screen because of that. Okay, I'll start.
Yes.
Good evening, I'm Dr. Gargi Bangar and I will be presenting on dengue presentation and diagnosis. Dengue is a, ma'am, I cannot see my own screen. All right. Dengue is a tropical disease caused by dengue virus. It has 4 serotypes. dengue 1, 2, 3, and 4. It is principally transmitted by Aedes aegypti. And the virus stays in the salivary glands of the mosquito for 8 to 10 days, with bites multiple humans, and the incubation period is for 4 to 7 days. Once dengue virus infects a human, it invades the multiplies there. They're then taken by the lymph nodes. Virus is amplified and disseminated throughout the lymphatic system, which causes primary viremia. Virus-infected macrophages release interferons, cytokines, chemokines, and TNF, which cause flu-like symptoms and pain. They also affect the hemostatic system. Endothelial cell dysfunction causes fluid from the blood vessels to leak out. This leads to third spacing. It is very important to remember that lower blood volume causes the low blood pressure in dengue. Dengue can also affect the bone marrow, resulting in lower cell counts. We often see patients coming with high-grade fever and multi-system involvement, such as pain, retroorbital pain, joint and muscle pain, vomiting, diarrhea, stomachache, and rashes. Febrile rash of dengue is blanches on pressure, something like this. Whenever a patient with dengue presents to us, we check if there is sepsis initially and follow the sepsis protocol. If not, we check for localizing signs and treat appropriately. If not, we wait for 1 or 2 days.
We cannot see the screen, PPT.
Yes, Dr. Gargi, please share your screen.
Is it visible now? Yeah.
Yes.
So febrile rash of dengue, blanches of pressure, something like this. And whenever a patient of fever comes to us, we check if there's sepsis. And if so, we follow the sepsis protocol. If not, we check for localizing signs and symptoms and treat appropriately. If not, we check for day of fever. For the first 48 hours, we defer investigations and do not start empirical antibiotics. On day 3 or 4, if the fever has not changed pattern, we go for investigations. And on day 5, we go for blood culture. As infectious disease doctors here, we will defer antimicrobials unless there's a specific indication to do so. So when a child has dengue fever, there's a febrile phase for the first 2 to 7 days. Here there's high fever and there may be dehydration due to vomiting, which may lead to decreased fluid and altered metabolic states. When the fever breaks down, parents are usually relieved, but this is when the critical period starts and plasma may leak for 24 to 48 hours, leading to which may lead to shock and death. There can also be hemorrhage at this stage. After the critical case stage has passed, there is convalescence period, wherein there is reabsorption of fluids. Here we need to realize, even though the vitals are stabilizing, there can be fluid overload. So why are we scared if dengue is self-resolving? So here's a proposed model of heterologous immunity in secondary dengue virus. On the left-hand side, we see pale light-colored cells. These are naive T cells. Let's assume that the ones in pink have higher avidity for DEN1 and the ones in blue have higher avidity for DEN2. During a primary illness, with DEN1, pink T cell population preferentially expands and enter the memory pool, which is seen as dark pink. Similarly, primary infection is when DEN2, the blue pool expands. However, if a child gets infected the next time with a different serotype, the previous sooner, which leads to suboptimal viral clearance mechanisms, which leads to less lysis of infected cells, less antiviral cytokines, less inflammatory cytokines, and increased inflammatory cytokines, which may lead to severe disease. So when we see a child with dengue fever, it is important to look for warning signs, as a child going into severe dengue is warning signs before. The progression from severe dengue is 8 to 24 hours. So it is very important during rounds that we check for abdominal pain, persistent vomiting, signs of fluid accumulation of pleural effusion, ascites, if there's any mucosal bleed, liver enlargement of more than 2 centimeters, or a rise in hematocrit. WHO categorizes dengue fever as dengue hemorrhagic fever as fever with hemorrhagic manifestations, low platelet count of less than 1 lakh, and increasing hematocrit of more than 20% of normal or more than 50% of baseline. We categorize them into 4 grades. The first grade has thrombocytopenia with hemoconcentration. The second has grade 1 plus spontaneous bleeding. The grade 3 has pulse pressure less than 20 millimeters of mercury, hypotension for age, cold, clammy extremities, and restlessness. And grade 4 has grade 3 plus profound shock. Grade 3 and 4 are noted as dengue shock syndrome. The spontaneous bleeding manifestations may look like this. As we can see here, when there's a primary infection, the virus appears first, followed by NS1, IgM appears, and then IgG follows. However, when there's a secondary infection, there is, in the acute phase, there is a high rise of IgG, which may lead to dengue hemorrhagic fever and dengue shock syndromes. We can determine ELISA antibody. We can determine the severity of the infection by seeing ELISA antibodies, IgG, IgM, IgG ratio. In primary infections, the IgM is going to be greater than 1.2 to 1.4 of IgGs. In secondary infections, IgM is going to be lesser than 1.2 to 1.4 of IgGs. The common causes of death in a child with dengue fever is hemorrhages revealed or concealed, like pulmonary hemorrhages, profound shock and multi-organ failure, and there can be fluid overload, which is an iatrogenic cause, so we need to be careful. So it's always important to remember that though most cases of dengue may be self-resolving, one case may land us in trouble. So it's always important to check for warning signs. Thank you.
Okay. You finished?
Yeah.
Fast in time. Dipti, 1 second. Please give me 1 second. Dear friends, MMC has granted 1 MMC point. So I request all the viewers to write your name, place, MMC registration number, and central IP registration number, please, in the chat box. Thank you. Over to Dipti, please.
Thank you, Dr. Gargi, for nice, crisp presentation. I request Dr. Mihir Sarkar, sir, for have the expert opinion and comment about the presentation, and if any query or you want to highlight something.
Dr. Ganesh, you can stop sharing for time being.
Hello?
Yes, you are audible.
I request Dr. Mihir Sarkar, sir.
It's okay, I'll take over. Thank you, Dr. Gargi. It was a wonderful, short, crisp, concise presentation. Just 2 questions. Does titers have anything to do with the severity of infection? Does titers, if a dengue IgM titer is very high, does it have anything to do with the severity of infection?
No, sir. If IgM titer is very high, it does not correlate with the severity of infection.
Thank you. Very point well taken. Second, dengue IgM card test. Would you recommend that?
Sir, it is preferable to do a quantitative test. However, if it's not available, a rapid test would be the card test to do.
So is the government of India recommending the card test?
No, sir.
So what is the government of India recommending?
All 3 together, the serology, NS1, IgG, and IgM, but it depends on the day of investigation.
Correct. Point well taken. Dengue IgM ELISA should be done. Wonderful presentation. I think so we can go to the next speaker. If there's anything in the chat box, we like to answer.
Thank
Later
you,
on,
sir.
we can take.
Thank you, Maninder sir and Dr. Gargi for the presentation, and sir, it's good coming.
Dr. Mihir wants to add something.
Yeah, so there's very nice presentation by Dr. Gargi. So I just want to clarify this: with the NS1 antigen, if it has any cross reactivity to other viruses, can there be a false positive things?
Yes, I think it is with other arboviruses, it can have false positivity.
Yes, so especially the West Nile virus and these viruses can have the cross reactivity, but that not due for them with the MAC ELISA. Initially, when we used to do the rapid test that we were telling about, so that was the problem in that time. But now, when we're using the MAC ELISA, it is more specific to the NS1 antigen of the dengue virus, so it is not a problem now.
Thank you, sir.
Thank you, Mihir sir, and thank you, Gargi, for the nice presentation and sir expert comments. After the presentation and dengue shock syndrome features and diagnosis, we will move on to the treatment protocols for dengue fever and dengue shock syndrome. I request Dr. Ganesh Misal, IIP Ahmednagar, to start his presentation and share the slide, please.
Good evening, respected dignitaries and all my colleagues. Thank you so much. Is it visible, ma'am?
Yes, it is visible.
Yes. So today I am going to talk on the dengue fever and dengue shock syndrome treatment protocol. So management. So treatment modality vary depending on the severity of the illness. So if it is a confirmed dengue fever, then treatment modality is very specific. In that case, we have to give the bed rest during the acute phase. Then, if fever is there, then cold tapin, we have to give the antibiotics for the lower the body temperature. And paracetamol is the drug of choice, and aspirin or NSAID should be avoided. Like ibuprofen or mefenamic acid should be avoided. Then fluid and electrolyte correction should be there, and intense monitoring should be there in confirmed dengue cases. So in intense monitoring, we have to monitor the blood pressure, urine output, then heart rate, and sensorium of the patient. If patient comes in a dengue febrile phase, that is day 1 to 3. Also, for control of the fever, we have to give the paracetamol in a dose of 10 mg per kg 6 hourly. Then we have to prefer the electrolyte-rich solutions like kanji water, oral rehydration solution, and fruit juices. Then, if needed, IV fluids we have to use judiciously in the febrile phase. And if you have to use the IV fluids, then we have to use 1.5 ml per kg per hour. Then our target urine output is 1 ml per kg with the stable vitals. And in dengue febrile phase, we are not going to use the hypotonic fluids, and preferably we are going to use only normal saline or ringer lactate. So we are going to see treatment protocol according to the grading of the dengue fever. So if patient comes in a dengue hemorrhagic fever 1 and 2, and if hemorrhagic manifestations are there or bleeding manifestations are there, patient is having thrombocytopenia or hematocrit rise is more than 20%, then in that case, we have to initiate the IV therapy with 6 ml per kg per hour crystalloid solution, preferably NS or RL, for 1 to 2 hours. After that, we have to see if there is improvement, then we have to continue the crystalloid NS or RL at 6 ml per kg per hour for 2 to 4 hours. And then we have to decrease the 3 ml per kg per hour for 2 to 4 hours. Again, if improvement is there, then we have to shift to 3 to 1.5 ml per kg per hour for 2 to 4 hours. And if there is further improvement is there, then after 24 to 48 hours, we have to discontinue the IV fluid therapy. Again, if there is no improvement is there, then again we have to look for the hematocrit. If hematocrit rise is there, then we have to increase the IV fluid from 6 to 10, and we have to give for 2 hours. Again, we have to look for the hematocrit. If improvement hematocrit is there, then again we have to decrease from 10 to 6 ml per kg per hour. If there is no improvement is there in hematocrit and hematocrit falls, then we have to suspect the internal hemorrhage or internal bleeding is there. And in that case, we are going to transfuse the blood. So if you are going to transfuse the whole blood, then 10 ml per kg whole blood is given. And if PCV is going to give, then it is given in 5 ml per kg. If there is further improvement is there, then we have to successfully reducing the flow from 10 to 6 and again from 6 to 3. And after 24 to 48 hours, we can discontinue the IV fluids. If patient comes in dengue hemorrhagic fever grade 3, so this is a condition where patient presented with a compensated shock and pulse pressure is less than 20 millimeter of mercury, then hypotension is there, that is systolic blood pressure is less than 90 millimeter of mercury, and high hematocrit is there, that is more than 20% rise from the baseline is there. So in this case, we have to initiate the IV therapy by 10 to 20 ml per kg per hour, NS or RL solution for 1 hour. If improvement in vital signs and hematocrit is there, then we have to slow down the IV fluids from 10 ml to 6 ml, 6 ml to 3 ml. And after that, if further improvement is there in vital signs, then we can discontinue the IV fluids after 24 to 48 hours. At the same time, we have to look for the if acidosis is there, bleeding is there, or hypocalcemia is there, or hyperglycemia or hypoglycemia is there. If it is there, then we have to treat that accordingly. Then in last case, dengue hemorrhagic fever grade 4, if hematocrit is there, If profound shock is there and signs of shock, that is hypotension, BP is undetectable, then a high hematocrit is there, that is more than 20% rise from the baseline is there, then in that case, we have to give the supplemental oxygen, and immediate rapid volume replacement we have to give with the 10 to 20 ml per kg of the crystalloid solution as rapid bolus over only 15 to 30 minutes. If improvement in vital signs and hematocrit is there, then start IV therapy by crystalloids successively, reducing from 10 to 6 and from 6 to 3 and 3 to 1.5 ml. So we have to look for the improvement. If further improvement is there in vital signs and hematocrit, then we have to discontinue the IV fluid after 24 to 48 hours. But if there is no improvement in vital signs, then again we have to repeat the 10 to 20 ml per kg of crystalloid or colloid solution as a second bolus over 15 to 30 minutes. Again, we have to check for the hematocrit. If there is improvement in hematocrit and vital signs is there, then we can drop down the IV fluids. If hematocrit rises and more than 45%, then IV colloid or crystalloid 10 to 20 ml per kg over 1 hour we have to give. If there is no improvement, then again we have to check the hematocrit. If hematocrit falls, we have to again suspect the bleeding. And if bleeding is there, again we are going to supposed to give whole blood or PCV. If in spite of giving that, if refractory hypotension is there, again we have to look for the acidosis is there or bleeding is there, calcium levels and sugar, hypoglycemia or hyperglycemia is there. If there is no improvement in vital signs, then we have to start with the IV inotropes with the crystalloid maintenance fluid according to the Holiday-Cigar formula. So all of you know that this is Holiday-Cigar formula. Then again, we have to look for the hemodynamic assessment of the whether patient is in a compensated shock or hypotensive shock. So what is the role of the inotropes? If child does not respond to all the above measures, if BP is unrecordable, then in that case we can give adrenaline infusion or noradrenaline infusion. If BP is normal with poor perfusion shock, then we can give the dobutamine infusion. What are the indications for the ventilation? Shock not responding to the fluids and is catecholamine refractory. Children presenting with the absent peripheral pulses with profound shock. Then we will see what is the criteria for the platelet transfusion. So prophylactic platelet transfusion, we are supposed to give if platelet count is less than 10,000 in absence of bleeding manifestation. And proper platelet transfusion indication is massive hemorrhage with or without thrombocytopenia before any major surgery, and ADP is preferred over the RDP, that is single donor platelets is preferred over the randomized donor platelets. So unnecessary platelet transfusion would result in adverse effects such as fluid overload, graft versus host reaction, and increased risk of the HIV or hepatitis B. So what is the discharge criteria for the patient? So clinically, we are going to see that is no fever for the last 48 hours, improvement in clinical status, general well-being, appetite is improved, hemodynamic status, urine output will be improved. There will be no respiratory distress. Also in lab parameters, there is increasing trend of the platelet count. Also WBC count is on increasing trend and stable hematocrit without intravenous fluids.
The slides are not visible, Dr. Dinesh. They are not moving.
Is it visible right now?
Stop sharing and reshare.
It is stuck to criteria of platelet transfusion. Yes.
Go to discharge criteria.
Yes. Yeah, discharge criteria. So clinical discharge criteria is there. If there is no fever for 48 hours, improvement in clinical status, that is generalized well-being is there, improvement in appetite is there, then urine output is improved and no respiratory distress is there. Then in lab parameters, increasing trend of the platelet count, stable hematocrit without intravenous fluids. And lastly, what are the dengue management do's and don'ts? So don't use corticosteroids. They are not indicated and can increase the risk of the GI bleeding, hyperglycemia, and immunosuppression. Don't give platelet transfusion for a low platelet count. platelet transfusion do not decrease the risk of severe bleeding and may instead lead to the fluid overload and prolonged hospitalization. Don't give half normal saline. Half normal saline should not be given even as a maintenance fluid because it leaks into the third space and may lead to the worsening of the ascites and pleural effusion. And lastly, don't assume that the IV fluids are necessarily. First, check if the patient can take the fluids orally. Use only minimum amount of the IV fluid to keep the patient well perfused. Decrease IV fluid rate as hemodynamic status improves or urine output increases. Thank you so much.
Thank you, Dr. Ganesh, for your presentation. I request Dr. Mihir Sarkar, sir, for the expert comments on this presentation, sir.
Yes, thank you. So this is a very informative presentation of the severe dengue and the dengue shock. Just want to be a bit cautious because the management of the severe dengue, it's with the dengue patient with some hemorrhagic fever or the fluid leak, or maybe the patient is shock, is basically the management of fluid because we don't have any drug. So that is basically supportive treatment. So that meticulous monitoring, not only the ordering the fluid, how we are ordering, what rate, and how we are monitoring, that is very important. So if you can see the flow chart that you have shown, they have shown that the monitoring of the patient, that taking the decision after every 1 hour or 2 hours, even if the patient is in shock, then every 15 minutes or 20 minutes. So best standing by the side of the patient at the bedside when the patient is sick, and the titration of the fluid is very important. Also your calculation of the urine output, what is the blood pressure, if the narrow pulse pressure is there, if it is becoming widening or it is becoming very narrow now, what is the pulse volume, okay, and plus the hematocrit, because in the bedside you not every 15 minutes or 1 hour you difficult to get the hematocrit value, but the other parameters you can check in the manually and by standing by the side of the patient, and that should be your goal. One thing is that the target is very important. Whenever I'm managing a patient with dengue, we should not target a optimistic target of normal value of blood pressure, normal value of urine output, that we may lead to overload the patient. Okay, so just keep the urine output more than 0.5 to more than 0.8 ml per kg per hour, and blood pressure above 50th centile is just sufficient. Do not target the blood pressure of normal blood pressure for that age or the sex or the height of the patient. Okay, so that is very important. And also the pulse pressure is very important point here. So that is we sometimes forget the pulse pressure, but if it is becoming the narrow pulse pressure initial is becoming widening, that is very important. And also the patient may do not have the shock, but they just have warning sign in the dengue hemorrhagic fever 1 and 2, don't have any capillary leak, but the patient just present with the pain, severe pain abdomen, or just lethargy or severe vomiting. In that case also your fluid should not be higher, that is 6 ml per kg per hour you have started. So you have to individualize, because the patient may be a very wide group of patient. According to the clinical presentation, you have to individualize. Who have not shock or sorry, no capillary leak, but we are starting 6 ml per kg, that will overload the patient. Okay, so that is the thing I want to highlight.
Maninder sir, you want to highlight something?
Dr. Ganesh, excellent presentation. I just love your don'ts. Now, will you give plasma to a patient as a fluid bolus? Dr. Ganesh.
No, sir. Preferable in colites. If you are.
No. My question is simple. Will you give plasma, yes or no, as a bolus?
No, sir.
You will not give. Correct.
No.
Why will you not give?
It will give the fluid overload, sir.
But it has albumin in it. It has plasma in it. Then why will you not give? Even you're giving colloid, which is albumin.
Yes.
Then why not give plasma?
Sorry, sir. Don't.
So there's a tendency of every one of us to give plasma. It is not good. Plasma can cause trali. Plasma can cause hypocalcemia. So this is the only type of shock. It is ABCS, not ABCD. In dengue, it is ABCS. A means acidosis, B means bleeding, C means hypocalcemia, and D is hypoglycemia. So ABCS. So we have to be very, very careful. So take home message, no steroids, no, until unless it is HLH, and no plasma. Ultimately, the patient will drown in fluids. The patient will die because we give so much fluids.
So
excellent presentation. Thank you.
Thank you, sir. Thank you.
During INR is Dinesh. Then we need to give FFP.
You are not audible, ma'am.
Time is Dinesh.
Loudly, please.
if PT is deranged, INR is
Okay. So coagulopathy in dengue is not unheard of, but a coagulopathy which can be corrected by vitamin K is okay. But during coagulopathy, if the child is bleeding, then definitely you have to correct that coagulopathy, which might be not due to prolonged PT, it might be hypofibrinogemia also. So maybe cryo might be more preferred as compared to FFP. So we have to
Yes.
move away from FFP.
Thank you, sir. Thank you for the nice presentation and expert comment by two experts. After dengue, we will move on to next disease, which is again mosquito, who is the vector for mosquito. Dr. Sanjini Magar, madam, from IIP Parbhani. She will present malarial fever presentation, present status, and current management in children. Madam, please start sharing your screen.
Very good evening to all.
Ma'am, make it full screen, please.
Yes.
A very good evening to all. Today I will be talking on present status of malaria fever and its current management in children. As we all know, malaria is a vector-borne infectious disease caused by 5 types of plasmodia, that is Plasmodium ovale, vivax, falciparum, malaria, and the newer one is the Wellesley. Now coming to the management part, for definitive treatment, diagnosis should be confirmed first. Now, how to diagnose? By microscopic examination of the PS or the RDT. Microscopic examination of the PS is the gold standard. It is confirmatory and useful in deciding prognosis and the assessment of response to therapy. Thick and thin smear, both are useful. Thick smear is more sensitive and thin smear is more specific of the diagnosis. The second test is RDT. It is screening test. It is simple, quick, but the only problem is it remains positive for 14 days, even after the complete cure of the malaria. And it is not useful in monitoring the drug response. Now, coming to the treatment of the uncomplicated Plasmodium vivax malaria, once the diagnosis is confirmed by RT or PS, in Plasmodium vivax malaria, chloroquine is the drug of choice, and only 4 doses of chloroquine, along with in addition of primaquine for 14 days is all that is needed for the complete cure of the Plasmodium vivax malaria. Now about chloroquine, it should not be given on an empty stomach, as vomiting is the most common side effect of it, and primaquine should be avoided in less than 5 kg babies and in children with G6PD deficient children. Now coming to the Plasmodium, uncomplicated Plasmodium falciparum malaria. There are 3 regimes of different artemisinin and artemisinin combination therapies. The first regime is artemisinin 4 mg orally, along with the sulfadoxime and pyrimethamine. The second one is artemether and lumefantrine, that is AL combination. And the third one is artesunate along with mefloquine. Now we will see the treatment of complicated or severe malaria. When you call it as severe malaria, a confirmed case of malaria with a parasitic index of more than 5%, and signs of multi-organ dysfunction like altered sensorium, convergence, respiratory distress, shock, oliguria, and jaundice. We label this case as a severe malaria. In all cases of severe malaria, we need to hospitalize in ICU, and at least one single dose of IV anti-malarial before referral will help in reducing the mortality. The rapid clinical diagnosis, stabilization of airway, breathing, and circulation is needed before transfer. Then you should correct dehydration and hypoglycemia before transfer. And these are the IV antimalarials available in the treatment of severe malaria. We give IV artesunate or artemether as long as the patient is not able to swallow. But once the patient is stabilized and is able to swallow, we would shift the patient on the oral combination therapies. Now, artesunate in the dose of 2.5 milligrams, 2.4 milligram per kg stat, and then at 24 hours, and then once daily till the patient is able to swallow. And the course is followed by ASP or AL combination. Now, treatment of complications of severe malaria. There are many complications like cerebral malaria. It is the most rapidly progressive and fatal complication of malaria. Convergence should be treated with lorazepam or midazolam. One should avoid anticerebral edema agents like steroid and mannitol, as race ICT is not a feature of cerebral malaria, and mefloquine is also contraindicated in cerebral malaria. Now, severe anemia, altered sensorium, needs PCV transfusion, lactic acidosis, hypoglycemia should be treated as with the other critical ill patients. If there is acute renal failure or DIC, it should be treated with hemodialysis, and for bleeding, FFP transfusion and low molecular weight heparin is needed. Now, few words about the recurrence and treatment failure. In Vivax malaria, if the recurrence occurs within 28 days, the retreatment with the same classes or regimes is needed. If it occurs after 28 days, the weekly suppressive therapy with 10 milligrams of pyrimethamine is needed for 6 months. Falciparum, in case of falciparum malaria, if the recurrence occurs within 28 days, it should be treated with an alternative regime. If the original regime was ACT regime, then the patient should be treated with quinine plus doxycycline plus clindamycin. If the recurrence after it recurs after 28 days, it is due to reinfection, and the same initial regime may be restarted. Now, in short, about the chemoprophylaxis, when we are traveling to the high incidence area, a short-term chemoprophylaxis, if we are going to stay there for less than 6 weeks, a doxycycline 1.5 milligram per kg once daily. We should start 2 days before arrival and continue for 4 weeks after leaving. In long-term prophylaxis is needed if we are going to stay for more than 6 weeks. Mefloquine 5 milligram per kg weekly. It should be started 2 weeks before and continued for 4 weeks after. The vaccine, the most awaited vaccine R21 Matrix M by Serum Institute of India is recommended for use by WHO. It will be available in next year. Thank you.
Dipti, you are not audible.
Thank you, ma'am, for completing the presentation within time, and the slides were very informative. I request our expert sir, Neil Sarkar sir, and Maninder sir to comment on that.
Okay. Thank you, Dr. Sanjeevani, for the nice overview and the overall covering the whole aspect of the malaria with a very short time. And it was very crisp presentation. So just I want to know if the patient have been RDT, rapid diagnostic test positive for falciparum, then will you go for again the slides test? And if why?
Can you stop screen sharing?
Sanjeevani, can you stop sharing your screen?
Yes. So if the patient is RDT positive.
Yes,
then,
yes, you have got the RDT is positive for falciparum malaria. So again, we'll go for the slide test.
Yes, sir. We
And
should
if
go for the slide test to see the parasitical index, whether it is severe malaria, and also to also after starting the treatment, you reassess the response to therapy.
excellent, excellent. So again, you have said that the for primaquine therapy, if the patient is on G6PD deficiency, then it is a contraindication. So will you go for testing each and every patient before starting primaquine for G6PD level?
No, sir. But if there is history of jaundice and if the prior reports are available, we should be cautious.
Excellent. So that is kept in mind that the government, the guideline of government of India and the WHO does not say that you have to do the G6PD level for every patient because there are certain pockets where the areas where only the G6PD deficiency is found, not all over the India and simultaneously. So that's why it is not routinely needed. But if yes, if the report is available with you, then you will stop. Otherwise, you can start and you have to counsel the parents then what are the things they have to monitor if their hemolysis occurs. So that is the very important point. Thank you.
I'll just add one question. Dr. Sanjeev, you told in Northeast India, where Mihir is staying, they are not using the combination therapy of artesunate and sulfadoxine pyrimethamine. They have gone for lumefantrine. Why?
Sir, resistance to sulfadoxine pyrimethamine is noted in our resistance states.
Suppose the kid is intubated in ICU and you have started your artesunate injection. What other injection will you add so as to combine the combination therapy? You have to give dual therapy. So what are the second IV medication that you want to add to treat complicated malaria? So either quinine or artesunate you will choose. So you have chosen artesunate. So with artesunate, which second IV medication would you choose? Maybe Mihir can answer.
Anti-malaria.
Which anti-malaria?
Second anti-malaria.
Correct. Which one?
You have already mentioned in the recrudescence and the other things in the later part.
It can be sometimes.
Sorry, sir. I
Mihir, would you like to tell?
Yeah, you can add the clindamycin here. So the IV clindamycin you can add. Okay.
So always give combination therapy. Always. Yeah. Thank you.
Thank you, sir. Thank you, Mahendra sir and Mihir sir. And thank you, Sanjay Madam, for the nice presentation and expert comments. After viral infections, we will switch on to bacterial infections. For this, I would like to call Dr. Ninad Chaudhary, who is from IIP Amravati for typhoid fever management. Dr. Ninad, please start sharing your screen.
Hello, ma'am. Is it visible?
Yes,
make it
yes,
slideshow.
you can start.
Yeah. Good evening, everyone. Myself, Dr. Ninad. I will cover the today previous topic, management of typhoid fever. Typhoid fever is caused by the bacterium Salmonella typhi, which is a gram-negative and the non-lactose fermenting bacteria. It is an intracellular bacteria, and it mostly affects the reticuloendothelial system with the intestinal lymphoid tissues and gallbladder. So it is a multi-system disease, and the diagnosis is mainly clinical. So in this presentation, we will see the management of typhoid fever. So first we will see the diagnosis. So in diagnosis, first we will see the hemogram. In hemogram, we look for the total leukocyte count, which is a normal or a low with neutrophilia, and sometimes it may present with the thrombocytopenia. In CBC, eosinopenia is a distinctive feature of typhoid fever, may not be seen in all patients, but it is commonly we will see. And in LFT, there is a mild elevation of transaminase levels if there is a liver involvement. Second important investigation is the culture and sensitivity. Out of this, blood culture is the gold standard and the most important investigation. The sensitivity is more in the first week. If as a protocol, if we present the patient long duration fever patient more than 5 days, we should send the blood culture before starting the antibiotics, as the yield of the blood culture is more in the first week. It is around 90%, and as the disease progress, it decreases and around 40% in the 4th week of illness. Automated blood culture system like BACTEC, which we are now commonly used, it improves the results. And as we see, the blood culture is gold standard. So this investigation, drawing the sample and the quantity of sample is also important. In pediatric patient, at least 5 ml blood we have to take for the good result and the yield. If we take the lesser amount of blood sample, you might get the spurious result or the negative blood culture. Second important is the bone marrow culture, which is important in the later stage of disease, especially in the PO cases. Many times blood culture is negative, or we will only get the clinically signs positive in enteric fever, but serology and everything is misleading. So you can go for the bone marrow culture, which is very important. Previously, then stool and urine culture. Previously, book said stool and urine cultures we can go, but nowadays it is not recommended due to the poor yield, and it may be sometime positive in the 3rd or the 4th week. Second important tests are the serology. These tests are not diagnostic, but only supportive for our management and diagnosis. So first is the Vidal test, which is widely used, and it is the I think it is the bread and butter for the practitioner. Vidal test positive, it is typhoid, you can start antibiotics. So what is the Vidal test? It detects the presence of antibodies against the H, that is flagellar antigen, and O, somatic antigen of the S typhi. Antibody titer of both O and H in the range of 1:160 dilution or more can be taken as a positive test. And but its sensitivity and specificity is low. The sensitivity specificity increase if we can go for the paired samples, and if it shows the 4-fold rise in the next week, then we can definitely go for this test, but it is sometimes cumbersome and not possible for the patients. Second test is typhi-dot test or enzyme immune assay. It is not very reliable test and need further robust evaluation. Specificity is only 37 to 40%. Then we go for the management. The general principle of management of typhoid fever are adequate rest and hydration. Second, attention for the correction of fluid and the electrolyte imbalance. Antipyretics, which is paracetamol 10 to 15 milligram per kg every 4 to 6 hourly, is important. And as the Salmonella typhi mostly hampers the reticuloendothelial system and digestive system, and so we have to go for the easy and the soft and easily digestible diet. So along with antibiotics, we have to go for this general principle, which is also important, which is the important role in the management. Now we go for the treatment, that is medicines. So nowadays there is increase reports of the antibiotic resistance in typhoid fever. The established resistance to the older antibiotics like ampicillin, chloramphenicol, trimethoxam sulfate, that is Ceftran, leads to the newer antibiotics. So which newer antibiotics we can use in typhoid fever, it is depend on the patient's condition. Like the patient is an outdoor OPD patient or the indoor serious, then it is seriously ill or mildly ill, patient present with complications or without complications. So these three parameters are important to choose the medicine. So in this table, we will see the choice of empirical therapy in typhoid fever, such as in patient condition, if the patient is severely ill, indoor patient, and if present with complications such as hepatitis or and other things. So first line of treatment is injection ceftriaxone. But if the patient is having concomitant hepatitis, then we go for the cefotaxime. Or if the patient is having penicillin allergy, then we go for the azithromycin. Second is the outdoor patient. If the patient is an outdoor, only mildly ill, no complications, can taken orally. So first choice is the cefixime, and second choice is azithromycin. But again, azithromycin is reserved drug. So we don't have to give azithromycin in each and every patient who are not responding to fever or first line treatment. We have to wait and watch. And now we jump to drug and doses. I think we all know this about the drug and doses. There is nothing new. But again, I will revise. Injection ceftriaxone we can give 100 milligram per kg per day. Cefotaxime is 150 to 200 milligram per kg per day. Important is oral cefixime and oral azithromycin. We routinely use in the 10 milligram per kg per day doses, but in typhoid fever, the doses are double. We have to take care of that. That cefixime is 20 and azithromycin is again 20. And fifth inject medicine is the azithromycin. So these are the commonly used medicines. Then again, we have to look for the defervescence. Defervescence means patient duration of the fever, means patient is having no duration, means no fever. So that is for defervescence. And we started antibiotics, then patient present with no fevers, then we have to take that duration in count. So treat the patient at least for 7 days after defervescence, means there is no fever spikes, or total 14 days, whichever is later. And for azithromycin, total duration is 7 days. So for the ceftriaxone and cefotaxime, we have go for 10 to 14 days, whichever is later, and we have to count the duration from the afebrile period. Now we go for the other medicines. So the role of steroid. Steroid is only indicated in severely ill admitted patients, like a patient is in shock, in coma, or having altered sensorium. So injection dexamethasone we can use in the dose of 3 milligram per kg, followed by 1 milligram per kg every 6 hourly for 2 days. And we can look for the improvement in the patient. If there is no improvement, we have to go for the we have to look for the other diagnosis or any missing link. So because long-term use, there is a chance of relapse. So we can go for 48 hours and then see the improvement. Quinolones, which is previously is very preferred medicine, nowadays not indicated in the pediatric age group and should not be used, as the quinolone resistance strain has been extremely prevalent in India. Many articles or many new studies shows the quinolone resistance strain is common in India and Southeast Asia. And aminoglycoside like amikacin has no role in management. As I already said, the Salmonella typhi is an intracellular, and it is aminoglycoside act as an extracellular sites. So now we see the response or how many days we can monitor the patient. So there is one entity called delayed response. Sometimes patient we started antibiotic, patient continuing having fever for 5-6 days. We run out our patients. We see we think, can we add the second line of drug? Can we continue this? So if by day of 7 of antibiotics, if there is no defervescence, but child look less toxic, increased duration of the fever spikes, and there is a quick response to antipyretics, then we can continue the same antibiotic till the day 10, and there is no need to panic and jump on the alternative medicine. Second important thing is recurrence of fever after 2 to 3 weeks after its initial resolution, called a relapse. And if there is a relapse of enteric fever, the treatment is with same drug we can use as we use in initial therapy. So delayed response is important. Delayed response phenomenon is very common in enteric fever because sometimes maybe the strain is mildly resistant and it takes some time. So now we go for this terminology like an MDR and XDR typhoid fever. MDR is multi-drug resistance typhoid. This strain of S. typhi is resistant to 3 basic medicines like ampicillin, cotrimoxazole, and chloramphenicol. If the culture sensitivity shows resistant to these 3 drugs, we can call it as an MDR typhoid. So first line drugs. Second,
Dr. Ninad, can you just summarize it, because we are, I think, already 12 minutes have gone.
Okay. Yeah, we can summarize, sir. So finally, the take-home message, last slide. Mainly diagnosis is clinical, blood culture is gold standard, serology is only supportive. Important in treatment now is a typhoid conjugate vaccine, which provide excellent protection against typhoid fever, including MDR, XDR. So we have to promote the typhoid conjugate vaccine, which is currently now only a single shot is recommended by IAP. Azithromycin is reserved drug, and it is a drug of choice in ceftriaxone resistant isolates. So typhoid fever can be treated with antibiotics, but resistance is increasing, so we have to take care of the antibiotic stewardness policy. So this is all from my side, sir. Thank you.
Okay, thank you, Dr. Ninad. Expert comment from Dr. Sarkar sir and
Yes, Dr. Ninad, very nice overview and of enteric fever. You have touched upon the various aspects. So I just want to know from you, what is the present status of the Vidal test and what is the fallacies of Vidal's test?
Sir, Vidal test actually is not the first line test. It is gives a false positive results, and it is specificity sensitivity is low. So first we have to do after 5 days of fever. If there is a high titer positive 1:1, 160 or 320 or 640, then only we can go for it is reliable. Less than 160 is not reliable, and sometimes other vector-borne diseases may give Vidal test positive. So blood culture is more important.
Yes, you are right. So especially in our country like India, so there may be repeated exposure of small salmonella infection. So the titer itself may be high, and also who are vaccinated, maybe the falsely titer may be high. And also the other, the malaria, rickettsial infection and other enterobacterial infection can give a false positive result. And it has been shown that the culture proven infection, 30% cases Vidal was negative. So that is the fallacy. So Vidal test is becoming like a Mantoux test of tuberculosis. So it's becoming a less reliable test. That's why the importance of the blood culture is becoming important. Though we know there are limitations from the peripheral centers, it is difficult to do the blood culture. But again, there is, if when you are talking about antimicrobial stewardship, because if you are sure that it is sensitive to some drug you are using, then you can wait till because there may be delayed response. So adding another drug, second line drug, that we can delay and we can reduce the resistance rate.
Yes.
I'll just add on to that. Another excellent presentation. So do you do Vidal and Typhidot in your practice?
So sometimes I do Vidal test, but I
देखो,
never.
दिल से बोलो, दिल से बोलो.
No, sir. Means only if the fever is more than 5 days, then I only do the Vidal test.
So
But if the patient is
I'll give a very straight answer. These two tests are obsolete.
absolute, yes, sir.
So stop using them. The moment you stop using them, the lab will think it's a waste test. They will also stop using it. So take home messages, please do not do the test. Second question is, suppose the report in blood culture comes ceftriaxone resistant. So would you give meropenem or would you add azithromycin?
Sir, it is depend on the patient's condition. If the patient
Is in ICU.
Sir, we can. It is ceftriaxone resistance. The guidelines is the given azithromycin. So we can start the azithromycin.
No, I'm not saying what the guideline. What do you do? Do you give meropenem or do you give azithromycin?
So if the patient is in ICU, we can give the meropenem. If the patient is taking orally well, then we can give the azithromycin.
Perfect answer. Very good. Thanks for that. Then somebody has answered the dexamethasone dose, 3 mg per kg. Suppose a child is 50 kg. So that comes to 150 mg. Will you give 150 mg?
No, sir.
You have written that's there in the guideline also. So
Yes.
what is the maximum dose of dexa that you have personally given?
Sir, actually, I never personally used dexamethasone in typhoid fever.
Okay, point well taken. Point well taken. And
Yes.
why do you think they have given such a high dose of dexa in typhoid fever?
Because, sir, I think that typhoid bacteria is intracellular. So,
okay, I'll keep the answer very simple.
That's why I think
it is a cytokine storm.
Okay.
And it was recognized way back in Jakarta in 1978. And they gave such a high dose of steroid as an anti-inflammatory dose. And they found almost 50% survival more in this dose. There's no other study which supports this dose. So 150 per mg for 50 kg is like very high. So myself, I only given 10 mg as a maximum stat dose.
Okay.
So such a high dose we don't use. If at all you want to give, you can give a pulse steroid also, 30 mg per kg. What is your point in that, Mihir? Would you like to add something?
Yes, so basically the high dose is based on the one single study that is way back that you have already mentioned. So there is no further study. So 3 mg per kg is, yes, in any other condition, we do not give such a high dose. Against our ceiling dose in a patient with 50 kg or obese is 12 mg in our practice. So we follow that. And with the use of antibiotics properly, then the complication rate, the hyperinflammatory state, that is becoming less. So we need to use the lesser number of steroids in enteric fever. But sometimes in ICU, yes, the case infrequently some complicated cases. In that case, you have to use them.
Thank you.
Okay.
Thank you, sir.
Thank you, Marinder sir and Mihir sir for the expert comments, and thank you, Dr. Ninath, for the presentation.
Thank you, ma'am. Thank you for the opportunity.
Now we have come to the last presentation. The finisher, Dr. Soham Kulkarni, is from IIP Kolhapur, and Dr. is presenting leptospirosis, diagnosis and management in children. Over to you, Dr. Soham. Please
Yes, ma'am.
start your presentation and share the screens.
Good evening, ma'am. Is it visible, ma'am?
Blank slide. Not yet.
Yes.
Yes.
Good evening, everyone. We'll start with the case scenario. There's a rainy season currently going on, and we're sitting in OPD. A 10-year-old child presents with complaints of fever, abdominal pain, myalgia, and headache. On examination, his temperature is 100.3 degree Fahrenheit. His heart rate is 90 per minute. His respiratory rate is 22 per minute. He has mild hepatomegaly and bilateral conjunctival suffusion. On further inquiry, he also gives history of roaming in flooded streets barefoot. Workup done using serological tests like ELISA and MAT confirmed diagnosis leptospirosis, and the child was treated accordingly. With this introduction, we'll start the presentation on leptospirosis. I am Dr. Soham Kulkarni. Leptospirosis is the most widespread zoonosis in the world. It is a bacterial infection caused by bacteria belonging to genus Leptospira, which is an aerobic motile spirochetes. There are 250 serovars of pathogenic Leptospira, which are further grouped into 24 serogroups. The incidence is 10 times more in tropical regions than in temperate zones. In India, it is mainly prevalent in South and Southwest India. The WHO leptospirosis burden epidemiological group estimation is there are 873,000 cases, which have 48,600 deaths annually. Pathogenesis is mainly an animal-borne infection. Both wild and domestic animals are involved. The reservoirs are cattle, horses, sheep, goat, pigs, dogs, and rodents. The most common reservoir is rodents. They shed organisms throughout their life, contaminating both water and soil. The entry portal are cuts, abraded skin, mucous membranes, or ingestion of contaminated foods or aerosols. Hence, the risk factors include agriculture workers, swimming, floods, and poor hygiene. The transmission is direct or indirect from animals to humans. Direct human-to-human transmission is very rare. Clinical features. The incubation period is 2 to 26 days. It mainly consists of two forms, anictric form and icteric form. The anictric form is commoner. It consists of non-specific symptoms like fever, headache, chills, and severe myalgia. They may have lymphadenopathy, maculopapular rash, and meningoencephalitis. In toddlers, they may have myocarditis and polycirrhosis. The icteric form is also known as Weil's syndrome. It is a severe form but less common. It mimics acute viral hepatitis, and it may coexist with hepatitis A infection, which leads to more prolonged and severe infection. Acute renal failure can also occur in few cases. The anicteric form consists of two phases, acute phase and the immune phase. The acute phase lasts for about 1 week and is a non-specific febrile illness, which is characterized by abrupt onset of fevers, rigors, and myalgias. The myalgias occur especially in calves and lower back, and a distinguishing feature is conjunctival suffusion, which occurs in about half of the patients. The second phase is the immune phase. A minority of patients experience this phase, which is characterized by return of fever, headache, and myalgia, which lasts for around 1 week. Aseptic meningitis and uveitis can occur in this phase. The icteric leptospirosis, that is Weil's syndrome, it is a rapidly progressive multisystem illness that occurs in 5 to 10% of patients and has mortality of 5 to 15%. Features include fever, jaundice, and renal failure. Pulmonary hemorrhage is a severe complication that is reported to be fatal. It occurs in around 50% of the affected patients. Diagnosis. The mainstay of diagnosis is by blood culture, whose sensitivity is 55.5% with specificity of 98.8%. Urine culture is also done in later stages, but it may take weeks to come positive. Serological tests include IgM ELISA, which may be positive after 5th day of illness, sensitivity being 80 to 90%. The other test is MAT, that is microscopic agglutination test. It requires two samples taken 2 weeks apart, and the test needs to be done in the same lab. Its sensitivity is 80% and specificity is 92%. Single titer of more than 1:800 is reasonable evidence of current infection. The other tests that can be done are dark field microscopy, histochemical staining, and immunostaining. There is a known cross-reactivity that occurs between leptospira and dengue IgM. It occurs when both are sent when clinical scenario doesn't give a clear picture for apt diagnosis. IgM antibodies are formed when patient suffers from one of the two infections, which may remain in the blood for a very long time. The second possibility may be poor specificity of the reagents that are used. Rapid tests of dengue have limited sensitivity and specificity, producing false positive results in patients with leptospirosis. Hence, it is crucial that diagnosis is not excluded early on. Other lab investigations include CBC, which may show polymorphonuclear predominance and thrombocytopenia. The peripheral sphere may show toxic granules in neutrophils. ESR and CRP will be elevated. LFTs will show elevated AST, ALT, bilirubin, and ALP. Urine analysis may be deranged, showing proteinuria, pyuria, or occasional hematuria. Lumbar puncture may show elevated opening pressure. Initially, it will have polymorphs, later on lymphocytes, and there will be only mild elevation of protein, and glucose will be normal. Diagnosis is based on modified Fain's criteria, which was given in 2012. It consists of 3 parts, that is part A, B, and C. Part A is clinical data, which includes headache, fever, both 2 points. If fever is more than 39 degrees Celsius, we have to add 2 more points. conjunctival suffusion bilaterally, meningism, and muscle pain. If they occur individually, we have to give them 4 points each. If they occur all together, we have to give a total of 10 points. Jaundice and albuminuria. Part B includes epidemiological factors like rainfall, contact with contaminated environment, and animal contact. And Part C includes bacteriological and lab findings. If Leptospira is identified on culture, the diagnosis is certain. Other tests include ELISA IgM positive, MAT single high titers, or MAT rising titers, which has a higher score. Presumptive diagnosis is made if Part A or Part A plus B or Part A plus B plus C have a score of more than 25. And the possible diagnosis is made if a score is between 20 and 25. Treatment, it depends if the child is sick or stable. If the child is stable, we can give 4 drugs, that is amoxicillin, azithromycin, cefixime, and doxycycline. All are given in the routine dosages. In sick children, which include children with meningoencephalitis, myocarditis, or renal involvement, we'll have to give IV medications, which include penicillin or ceftriaxone, which is also given in the usual dosages. Supportive care include monitoring of vital parameters and hemodynamic assessment, maintenance of fluid electrolyte balance, treatment of cardiovascular collapse, and if child has renal failure, we might refer for dialysis. Prevention is equally important. First is rodent control. Second is avoidance of contact with contaminated water and soil. Children should not be advised to or allowed to wade through flood waters or plain stagnant pools. Livestock can be immunized and pet animals can also be immunized. Thank you.
Okay, thank you. Thank you for the initial one. I request Dr. Maninder sir for expert comment, please.
Excellent presentation. Just have one question, Soham.
Yes, sir.
In your area of practice, other than blood culture, what other tests are there which you can order to diagnose leptospirosis? Not the
Usually we
theoretical part, not the theoretical part, the practical
Yes,
part.
sir. We have only IgM leptospira available, sir. IgM
So,
test.
suppose in a dengue season, the IgM lepto is also positive and dengue is also positive. So what will you do?
We'll have to take it with
Typhoid dot is also positive.
that leads to very confusing scenario, sir. We'll have to look at the features of the patient, sir.
Correct.
Whichever
Correct. So
match.
ultimately, it's the clinical presentation.
Yes, sir.
We have to match with the clinical presentation. That's the only take-home point. Perfect. Thank you.
Yes, sir.
Yes, sir, your expert comments.
Yes, excellent presentation, Dr. Soham.
Thank you, sir.
And you have covered almost everything. So can you just tell what is the percentage of this icteric? Because leptospira has come our mind at the icteric, this patient having jaundice and the red conjunctiva. So what exactly the percentage of patient we get the jaundice in the leptospira?
Icteric leptospirosis, that is Weil's disease, sir, occurs in only about 5 to 10% of the cases. And bilateral conjunctival suffusion occurs in around more than 50% cases, sir.
Yes, so icteris is slightly higher than what you have said. So it is the 20 to 25%. So the point that I want to make is that you need a very high index of suspicion. If the patient having this epidemiological background with the fever for high-grade fever for 4 or 5 days, then patient with maybe the similar findings with scrub typhus, similar findings with the dengue or the enteric fever also. So you need a high index of suspicion. Because initially during the febrile phase or this bacteremic phase, you will not get the typical signs. So whenever a patient goes to the second week when immunological phase, you will get the all typical signs. So you need a high index of suspicion.
Thank you, Maninder sir and Mihir sir for the expert comments. And we have covered almost all protozoal, viral, bacterial infections, and it is covered very well within time. Thank you for the speakers' hard work and their risk and concise presentation. Now I will session to Manjusha ma'am. Manjusha ma'am, please have words.
Thanks, Dr. Deepti. Indeed, it was an excellent session today. Entire day was very much brainstorming. So let us conclude today's program with a vote of thanks. Today we had an excellent sessions on an important clinical topic of infectious diseases, and wholeheartedly I express my gratitude towards Dr. Mihir Sarkar and Dr. Maninder Dhaliwal sir for sincerely guiding us and guiding our speakers, presentations so well. Thank you so much, sir, for accepting our invitation as an expert, and your expertise guidance definitely will help us in managing our critical patients. Once again, thanks on behalf of Maha IIP Women Committee. See you in the next session somewhere, sir. Thank you so much. I sincerely thank respected Dr. Basavaraja sir for your gracious presence and guidance and inspiration. I would like to thank our Maha IIP President Dr. Ramakant Patil sir and Secretary General Dr. Amol Pawar sir for guiding us, supporting and encouraging to conduct each and every Tuesday text consistently. Thank you so much, Ramakant sir and Amol sir. Thank you, Dr. Vaibhav Pustake sir, being MMC observer and granting us 1 MMC point. And thanks for joining and giving us an inspiration. I thank all the talented speakers, Dr. Gargi, Dr. Ganesh, Dr. Sanjivani, Dr. Ninand, and Dr. Soham for your excellent presentations. And you could answer each and every expert's question. I'm so happy for that. It was a little scary situation, but they stood your examination points. I'm so happy with all, and hearty congratulations to each and every speaker. I thank you to our Women Committee Chairperson, Dr. Sonali Shirbhate, and Co-Chairperson, Dr. Neha Singh, for your precious guidance. Thanks my co-moderator, Dr. Dipti Deshmukh, and all the zonal coordinators for helping us in providing excellent speakers from all 5 zones of Maharashtra and smooth conduct of the program. Thank you, all of you. Thanks all EBs, OBs of Maha IIP for joining with us today. And thank you, dear Pallavi ma'am, for your consistent digital support, and the most important appreciation and thanks to all my viewers, colleagues who have joined enthusiastically with us from Zoom and YouTube as well in a large number. More than hundreds of viewers were there today. Thank you so much. We expect the same support and motivation from all of you for the next Tuesday text. Till then, take good care of you and good night. Thank you so much. Here I end this.